I came to Canada about 15 years ago, and I've been incredibly lucky and incredibly grateful for what this country has given to me since arriving here. Today I'm going to talk, the title of the talk is A High-Tech Look at Parkinson's and the Eye. That's there's a bit of tongue-in-cheek there. You'll see, as has been mentioned, I wear many hats, and that means I've got too many bosses. I have to duck and weave to keep out of the way, but my main affiliation is at University of Waterloo. So I'm going to talk a little about myself because I'm about to tell you something that may surprise you. It gives my perspective of this meeting, makes it a little different. I'm going to talk to you about the Ontario Neurodegenerative Research Initiative, or the ONDRI study, which I'm centrally involved in. And then I'm going to present some eye-related symptomatology findings for you, so the sort of things that people with Parkinson's notice in terms of eye symptoms. We've gone through all of this, so you needn't look at it again, really. It just has my scientific or career background. I always say that the more letters you have after your name, it's inversely proportional to your IQ. So I've got way too many. But I have colleagues actually who have more, and I always point that out, that they've got more letters than me, so they must be not as smart as I am. But in terms of my personal life, I love the outdoors. That's the trailer that we go to near Southampton on Arran Lake, and that deck I built with my own hands. We have a boat, we go fishing, we go water skiing. There's my two kids kayaking. There's Alicia, my daughter, on the back of the boat being pulled along on a towable. She looks terrified or happy, I can't work out which. And my other passion in life is Everton Football Club, which will mean nothing to many of you, but they're a Premier League soccer team. I was diagnosed with young onset Parkinson's disease in 2003. I was 41 years of age at the time, and I've now lived with Parkinson's for 12 years. At the same time, I was diagnosed with something called thoracic outlet syndrome. I knew very little about thoracic outlet syndrome at that point in time, and I thought I knew a lot about Parkinson's, but I didn't. What I anticipated would happen didn't happen. My story is an interesting one in the respect that basically Parkinson's became a sideshow because TOS was so invasive in terms of its impact upon my life. I think most of you will know that the definition of young onset really is before 50. It varies a little. Some people will say before 40 years of age, 45, but I think most people take it around 50 at the moment. Thoracic outlet syndrome it's a collection of conditions which together form a syndrome. So you have pain and numbness, tingling and weakness in the arm, hand and shoulder, neck and upper back as also, and it's due to pressure on the nerves and blood vessels, actually in the shoulder. It's quite unusual. A lot of people haven't heard of it until they're told about it by somebody like myself. And the secondary complications associated with it are stroke and heart attack. So in a way, it's a killer, but and that's because it incapacitates you. You don't want to walk around with thoracic outlet syndrome because the minute you do, your shoulder starts to droop, and that causes pain. In my case, the pain was severe. It was unrelenting. And the best way I can describe it is it felt like a golf ball was in my armpit and being compressed continually. And it was nauseating. And it would carry on through night, day, nothing would stop it. I was on morphine, oxycodone, and a neural painkiller as well. And in the end, they weren't worth the effort of taking them. I found better pain relief with chocolate or with sipping cold water, believe it or not. No physical exercise. I've always been into fitness and running and stuff. I didn't exercise, I think, for 3 or 4 years. And the way in which you got some relief was to actually adopt this sort of position, which you can see on the slide here, where you actually take the weight off your shoulder. That picture isn't quite right. That lady actually needs more weight bearing actually right underneath her elbow. I had problems getting people to recognize what the problem was. Most doctors attributed the pain that I was suffering from as PD. And they couldn't see past those signs. I consulted 8 thoracic surgeons in Canada, and none of them offered me a strategy that worked. Basically, the healthcare system failed me. And by 2011, I knew that I actually had advanced thoracic outlet syndrome because I'd had a venogram. So like an X-ray with dye in the blood vessels in my shoulders and arms. And the venogram, according to the radiologist, was the most advanced case of thoracic outlet syndrome he'd seen. But when I went back to the vascular surgeon who ordered the venogram, his comment was, no, it's due to Parkinson's. I had to push through the resistance that I was facing. Now, not all the doctors were against me. My own neurologist picked up the letter from the vascular surgeon and threw it across the desk in disgust. So there were people who were on my side, but it was a real battle. This is just a little hard to interpret, but what I would say to you is let me go this side. The angiogram, or the venogram that you see here, these are the blood vessels in my shoulders. And when I lift my shoulders up from here to here, that's called Adson's maneuver. And you can actually see that the blood is less apparent on the right-hand side than it is on the left-hand side. There's actually a position where it's nicked as well. It's harder to see. But that angiogram, or venogram, is very persuasive. It's so persuasive that when I was in Denver, where I actually ended up having the surgery, the specialist looked at the angiogram, put it down, and ordered my surgery straight away for 2 days' time. How do you deal with these situations? Well, I guess I don't take no for an answer very easily. I can be tenacious, I can be resilient, I'm known as a hard worker in terms of my research, and I can be defiant if I have to be, and I had to be. Some of the quotes there, who dares wins, is, I think that's the part of the services. But I like this quote, you never know how strong you are until being strong is the only choice you have. And that's what I had to be. So I ended up in Denver. That was in 2012. I managed to get OHIP to actually pay for out-of-province treatment. I dealt with that aspect of things as a grant application. And I identified Denver as being the place to go because I did a literature search and I found the site that was producing the most papers on thoracic outlet syndrome. As it happened, I found out when I got there that they were the US National Referral Centre for thoracic outlet syndrome. And when I arrived, there was a lady from Scotland in exactly the same position as myself because she couldn't find anybody in the UK to deal with her problem. The diagnosis was confirmed by the venogram that I just showed you a few minutes ago, and the surgery included removal of a rib on the right-hand side of my neck, a small rib right up in the neck, shifting of the scalene muscles on the side of my neck here, shifting of a muscle in my chest, and then decompression of the nerves and blood vessels to my right arm. By October 2012, I was pain-free, and I started exercising. I exercise now an hour every morning, almost without exception, certainly 6 days a week. And I made a remarkable recovery, and I put that down to the skill of the surgeons in Denver. They were superb. These guys are not just shoulder surgeons. They're neurosurgeons and vascular surgeons combined. Their training for this aspect is long and arduous. What happened, though, then really surprised me. Within a few days of the pain going, and the pain suddenly went in my shoulder, I became an old man. I had a shuffling gait, I was stooped in my posture, and became fatigued very quickly. And up until this point in time, Parkinson's had been there, but it was irrelevant. I'd had it in the background. I just pushed it away because all I could deal with was the thoracic outlet syndrome. I guess to some extent, the meds that I was on as well were helping suppress it. And at this point in time now, I was beginning to reduce the meds. And so the Parkinson's showed. And I was still fighting with the idea that I still had Parkinson's. And this is like 9 years along the way. But I guess I'd been distracted by other things. The one thing I knew for sure, whether I had Parkinson's or anything else, if I was going to get back on my feet, I had to start exercising. I also did some reading, and this book by Anthony Skelter, I think it is, was very useful for me. It helped me sort of like form a way forward. And also Bear Grylls, many of you may not know him, but he's basically a TV star now who, when he was in the services in the UK, jumped out of a plane and his parachute didn't work properly, or he had an accident, compressed his spine and was told he would never walk again. This guy walks now, runs, jumps, whatever he wants to do. So people like that, or books like that, were an inspiration. What was interesting was I was taking Parkinson's meds. I was taking Sinemet at that time, but I was completely ignorant of how to take them. So I was actually taking my Sinemet with milk, which is the last thing you want to do. I wasn't being rigid in terms of my dose. Hydration was never pointed out to me. In terms of my food intake, I was wondering at that time why, if I had a steak one day, the next day my symptoms were just awful, unmanageable. And basically, the idea of coordinating when I took my meds with when I took food just never crossed my mind. And of course, until I was out of the pain, I couldn't exercise. All of those things now I take seriously. I'm quite rigid with my dosing, etc., and how I take my meds, when I take the meds, when I eat, what I eat. I avoid red meats, particularly bloody red meats, and egg is a real problem. If I eat egg, I can be ill for the rest of the day, so I tend to avoid that as well. Exercise basically improved all my symptoms. I became upright, I got my posture back, my tremor reduced dramatically, my ability to think improved as well. And I then started to read quotes like, exercise is now considered by most authorities to be the new medicine for people with PD. In my case, and everybody's different, exercise needs to be vigorous. I need to be breathing hard. I can't talk while I'm exercising. And basically, unless there's a pool of sweat on the floor, I'm not working hard enough. Thankfully for me, I don't have any problems so far, touch wood, with depression. But again, that's another issue that needs to be considered when we're talking about Parkinson's, of course. Really, this diagram just shows how things changed over time for me. In October 2003, Parkinson's was probably the more prominent problem. By April 2012, TOS was a huge problem and Parkinson's was irrelevant, and it had gone worse over that period. And then by October 2012, TOS had reduced, and now Parkinson's was the main problem. And now Parkinson's is an issue for me. TOS is a very small issue for me. What residual pain I have is very minor. And I've not taken any painkillers, paracetamol or ever anything else since coming off morphine and oxycodone and the neural painkiller. I'm back to work. I wasn't expected to get back to work. In fact, both my employer and my long-term disability advisor said my work was probably over, my days of being useful in terms of work. This is a gravestone. It's my gravestone. Has my name on it, and I found that in a graveyard in the Lake District in the UK. And so when I look at that, I always remember the people telling me that my job was over, because it had a crushing effect on me. I love my job, as you'll see hopefully in a minute. I like this quote. I need to go closer to read it. It may shape me, but it won't break me. And I think that's on some of the badges on the tables as well. That's very much my attitude. Interestingly, there was a kickback from the toss. In December 2012, I was swimming. One day I could swim 80 lengths of the pool, and the next day I could only swim 6. And I had tightening in my chest. I had a cardiac embolism, a blockage. They rushed me into hospital. I had a stent done, and I didn't have a day off work. I didn't miss a day off work. It was in December 21st, and so the university had closed down for the Christmas period. Within a week, I was back exercising, and I now have no restraints whatsoever on my exercise. I sprint, I run long distances, lift weights, whatever. The thing I would say to you is, if any of you end up in this situation, you must be your own health advocate. At all costs, resist being herded in a direction that you feel it's wrong. If your body is telling you, my shoulder is aching and this has nothing to do with Parkinson's, stick to it. Stick to your guns. Don't back off. And just keep pushing. Push the doctors, push for another opinion. Keep pushing. So, that's me. And I don't mention it because I'm self-centered. I mention it because of the audience, and some of you, I think, might be interested in some of the information that comes out there. What I wanted to talk to you about was the Ontario Neurodegenerative Research Initiative, which I mentioned already. This study is funded by the Ontario Brain Institute, and it represents a collection of government, charitable and industry funding in order to learn more about the brain and how the brain misfunctions and the development of new treatments for diseases such as Parkinson's disease, Alzheimer's, ALS, etc. And it's a multi-center 5-year longitudinal study. So what that means is we're actually studying people repeatedly over a period of 5 years, and we hope to at least see most people for a three-year period. And the idea is to define the natural history of CNS diseases associated with dementia. And what we anticipate is that the study won't stop. So when we come to the end of the first 5 years of funding, hopefully there'll be more funding, and it will actually then turn into a controlled treatment trial. But the phenomenal thing about this is we don't know the natural history of CNS disease. And if we don't know the natural history, how can we tell that any treatment, whether it be an existing treatment or a new treatment, is going to have an impact upon the disease? We can't. So in many ways, we're at stage 1, defining the natural history and then making the appropriate or developing the appropriate outcome measures that are sensitive enough to show the impact of some of the new treatments which are lining up for all of these diseases. Why am I involved? I think I was one of the first people to use this as a quote, and now everybody's using it. I used it in some of my grant applications. The eye is a window into the body. It's unique in many ways. The metabolic rate is the highest of any tissue in the body. So in other words, it consumes glucose and oxygen at a rate which is much higher than any other organ in the body. That generates high retinal blood flow, which again is the highest in the body. The external tissue pressure is very high, so there's a pressure on the retina from within the eye, which is extremely high. And all the tissues are transparent, so they're quite unique. If they have nuclei, the cell components are pushed to the side so that the cell bodies are transparent. So if you can see out of your eyes, we can see into them. And that's what the diagram at the bottom is trying to show there. And it's the only place in the body where we can non-invasively look at the blood vessels, so we don't have to resort to surgery. This is a healthy eye. So what we're talking about here is here's the front of the eye, the lens and the cornea, and here we have the retina at the back, and this is a plain view, a flat view of the retina. Here you have the optic nerve, and that optic nerve connects directly to the brain. Here you have the blood vessels coming out of the center of the optic nerve and distributing across the surface of what's called the retina. So if you hear me talk about the retina, that's what I'm talking about, that structure there. And of course, most people have two eyes. The two retina coordinate all the information that comes into the brain, or the brain coordinates all the information that comes in via the two retinas. There are many diseases that impact the eye. Those diseases particularly would be diabetes, blood pressure, atherosclerosis, anemia, heart disease, stroke. Many of these diseases can be either predicted or monitored using the eye as the basis for that. And they result in things like hemorrhaging and fat deposits in the retina as well. But there's been some interest for a number of years now in the possibility that the retina could also reflect changes in CNS diseases, certainly multiple sclerosis, it can. And there's increasing evidence that in Alzheimer's and Parkinson's, that the rate of nerve fiber loss in that structure correlates very closely with the rate of grey matter loss in the brain. In terms of my work, what I've really been involved in over the last 20 years or longer has been development of new methods to non-invasively look at the back of the eye to get improved tools to look at diseases. And at the moment, what we've most recently been working on is being able to measure the oxygen content of the blood actually in the retina. So when you put that finger clip on your finger in the hospital and they're measuring the oxygen content, they're measuring it in your fingers, we're actually interested in measuring it in the eye because a lot of ocular diseases cause a loss of blood supply, and that loss of blood supply results in what we call hypoxia, or not enough oxygen delivered to the tissues. So I've said the eye is a window into the body. The next thing is the eye is an extension of the brain, and it truly is. The nerve cells that actually come from the retina travel down the optic nerve. They travel either to the lateral geniculate nucleus and then onto the visual cortex, and some of them actually travel just to the side of the lateral geniculate nucleus and go straight to the cortex. Most of them synapse, so they make like a plug connection at the lateral geniculate nucleus and then go onto the visual cortex. So these nerves are like 30 centimeters long. I was talking to you about the Andre study and the need to understand the natural history. I think some of you will know this guy. It's Tony Lang. He's a colleague in the Toronto Western Research Institute. And you couldn't actually meet a nicer guy. He's supremely busy, but he always has time for people. And his words are, we need a better understanding of many aspects of brain dysfunction in Parkinson's and how they correlate with one another. Understanding will lead to greater recognition of the clinical problems and more effective treatment attempts at developing new treatments. So what he's saying there is the challenge at the moment is to understand the disease and to develop better outcome measures to actually measure the disease. We're going to play a video now, so I'll just go on. This is a video from the Ontario
in Canada,
Andre study.
Nearly 750,000 people are living with some form of dementia. In the next 2 decades, that number is expected to double, having the potential to become the single greatest burden on our healthcare system. Dementia affects a person's ability to think, remember, and move, and eventually work, socialize, and be independent as the brain becomes damaged from a loss of brain cells. What can we do now to alter these alarming trends? What we're doing is called the Ontario Neurodegenerative Disease Research Initiative, or ONDRI for short. ANDRI is a research program that's studying dementia as one common aspect among 5 neurodegenerative diseases: Alzheimer's disease and mild cognitive impairment, Parkinson's disease, amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, frontotemporal lobar degeneration, and vascular cognitive impairment. Instead of only studying what's unique about the diseases, we're also analyzing the interaction between the 5 diseases by looking for early indicators, commonalities, and distinguishing characteristics. We'll identify unique biological markers that will help with earlier diagnoses and make discoveries that could result in the development of novel treatments. This is the first study in Canada where researchers and clinicians, patient advocacy groups, and the industrial sector are collaborating to collect large amounts of data on neurodegenerative diseases. Patient advocacy groups and the industrial sector are being engaged early to ensure that patients' needs are put first and the commercialization of research outcomes becomes a priority as opposed to an afterthought. ANDRI's mandate is to ensure that the findings from the data collected are transformed into new diagnostic methods that will help detect diseases earlier, improved clinical practice that put patients first, and eventually new effective treatments that will slow the diseases from progressing or even prevent the disease so people can continue to enjoy the later years of their lives. Participants will be observed for up to 3 years and will participate in a series of assessments. Gait and balance. Genomics. Eye tracking. Retinal nerve layer thickness measurements. Neuropsychological evaluations. Neuroimaging. The data from participants will be placed into a database, and investigators will be able to analyze the data across 3 dimensions: assessment, disease, and time in endless combinations. For example, if we discover that all Parkinson's patients have specific eye movements before they start exhibiting other symptoms, we'll be able to tell doctors to look for the signs to help with prevention, diagnosis, and treatment. This study could revolutionize the way neurodegenerative diseases are diagnosed and treated, ultimately improving the quality of life for patients. Follow us at andri.ca.
That's a very nice summary of what the ANDRI study is about, and it puts it in words that everybody can understand. So my role in the study, and why they approached me, I don't know, but they decided to approach me, and they asked me to be the ocular platform lead, so the eye study guy. And at the time, I was about to have surgery, and I went, no, I can't do it. And one of my colleagues, Barry Greenberg, said, yes, you can, Chris, so long as I do it with you. So he took the load for me when I was ill. And since I've come back, I've reciprocated. I've given him an easier time, which is good. In terms of the eye, the thing that I'm most interested in is this thing called SDOCT, Spectral Domain Optical Coherence Tomography. Laser photography of the eye, in effect, if you like. There's also looking at amyloid deposition in the retina. Amyloid is involved in both specifically Alzheimer's disease, but also Parkinson's, eye movements, and there may be more studies added as time goes on. So SDOCT, laser photography, is the equivalent of MRI of the eye in the eye imaging world. And this is an instrument that you can see here. And what it does, it allows us to get high-resolution cross-sectional images of retinal tissue. The retinal tissue itself is transparent. So underneath this layer, this grey layer here, at the very bottom are the rods and cones. And the light comes in from this direction, from this side. So the light actually goes through the neural layers before hitting the rods and cones. So the eye's like engineered back to front. You'd think that the rods and cones would be at the front end of things, but it's not. And in a way, you're all familiar with this sort of imaging because most of you will have seen hopefully ultrasound images of babies prior to being born. And it is basically an ultrasound technique, but it uses light energy instead of sound energy. And it's a very new technique. It's continuously developing, continuously changing. So this really just shows you how the ultrasound images are generated. As the image, or as the light goes through this section of retina, it has different reflectances shown on this graph here, according to the specific layer. And basically a computer analyzes and designates tissue levels based on the sequence of the reflections. So it relates the reflections to the particular characteristic of the tissue at a certain depth, and then can generate structural images or morphological images for us. And what the technique does, because of computerization again, is it puts a series of sections together, and then we can actually generate a three-dimensional view of the eye. Now the thing about the eye is, in a human being, it doesn't stay still, so it's actually continually moving. And the technology actually accounts for that. This is really like Star Wars technology now. We're looking at a moving target, and we want to hit it at exactly the same point. In other words, we want to image it or photograph it at exactly the same point, and the technology allows us to do that now. We're at that point in time. So in the image here, you'll see that the two scans are not quite aligned the same. So in the final scan here, there's a tilt on the image, on the box, and it's displaced differently in terms of its X and Y position. So this is the baseline scan, this is the second scan, and then you put the second one over the baseline, and you have to shift it. You have to shift it both sideways, up and down, and give it some tilt as well. And hopefully it's not distorted, because it can be distorted. If it's distorted, there's then further image alignment to take place. This is all about image registration again. In other words, that positioning of the images so that they line up properly. And then the other thing that we do as well is we don't just take one image, because one image is a bit grainy on its own. But if we take a number of images and we add them together, average them, random noise or speckle that has nothing to do with the image really, or the information that we're interested in, gets cancelled out, whereas prominent features which repeat show better. They become more clearly visible. And that's what this shows here. There's a number of manufacturers of this instrument, and I'm not going to tell you even which one we're using as part of the honorary study, but we've actually harmonized it, we've standardized it across all the studies. And basically what we can do now is you can take a schematic, and you can relate the schematic of the retinal structures that we know from microscopy, in other words sectioning, histology studies, and relate them to the non-invasive OCT image here. And now we go a step further. Now we've got a true section of a retina on the left there. So that's a sectioned image of human retina. The tissue has been frozen and then cut to show up all the various layers. And we know what each of these layers of the retina does, what its function is. And then we can relate that again to the OCT image. And this, with the use of computerization again now, we can actually segment each of those layers, not just along a certain point, but across the whole of the image, across the whole of that 3D image. And that then allows us to generate maps of the various layers. So I think this is the ganglion cell layer here, and then we actually go down deeper into the retina, closer to the bottom of that cross section there, showing various structures in terms of a three-dimensional map. The bottom line, the question we're trying to answer is, can we use SD-OCT to predict the development of CNS neurodegenerative disease? And then we'd actually, if we can prove that, we can then utilize that to initiate or to be used in controlled treatment trials with new pharmacological agents. And to be honest with you, it's not the pharmacology that's holding back drug development at the moment for these diseases. It's this point. The endpoints, proper study outcomes is holding things back. And the big advantage of SD-OCT compared to, say, an MRI is it's much cheaper, it's quicker, and it's widely available. Many optometrist practices now have an OCT in them. And this is some of the sort of evidence that's coming out. This is brand new, just came out last month, from a Chinese research group, and they're actually showing a relationship between thickness of one of those retinal layers and the advancement of Alzheimer's disease in this case. And they're actually showing separation. In other words, there's clear separation of the disease group versus the control groups. So that's it. We don't have any results from the ONRI study yet. We've been going about 6 months in terms of data collection, but certainly in 12 months' time we should have real data to show you. I wanted to talk a little about symptomatology in Parkinson's disease, because this is an interesting subject just to get involved in. Last week, the week before, it's blurred now, I've been all over the place over the last couple of weeks. I was in Denver, and the temperature here was 27 degrees, balmy, nice, and in Denver it was 7 degrees, cold, wet and murky. It was horrible. Normally they hold this conference in Florida and we go fishing and all sorts, but not this year. So these are 3 of my students. The conference is called the Association for Research in Vision and Ophthalmology. This is Edmund. He's now an ophthalmology trainee. Suseeth is a retinal specialist from Sri Lanka who I think is going to end up with a job in Australia. And Kalpana is a student, an optometry student from India. They're all 3 of them super smart and great students. When I was there, I met one of my friends. Helene Kagote is a professor in the other Canadian optometry school in Montreal, the French-speaking school. And she's done some, I was aware already that she got funding from CIHR, the Canadian Institutes of Health Research, to do Parkinson's-related research. And she presented her work at ARVO, so this is hot off the press. And these results compare the symptoms of 82 people with Parkinson's versus 82 people without Parkinson's. You can't see it because it's too small. I should have blown it up better, but it's a series of questions that relate to something called convergence insufficiency. So I know there are many symptoms associated with Parkinson's disease, but most of them have not been proven in a controlled treatment trial or a controlled study. So many of you complain of driving at night, for example, but many people without Parkinson's complain of exactly the same thing. We're actually looking with Dr. Almeida at the Movement Disorder Research Center at the moment to see if we can measure differences in depth perception between people with Parkinson's and without. And I can tell you, if it's there, it's small. We're trying to find it, we think we're onto it, but it is a very small difference. The thing about this study was it was controlled. They had a non-Parkinson's sample and they compared it to a Parkinson's sample, and the subjects were age-matched across the 2 groups. And what they found, first of all, was that people with Parkinson's have a deficiency in terms of converging their eyes. So if I look here, I can look at my finger. People with Parkinson's can only look so far. It pushes out, and it's called convergence insufficiency. And they then went on to look at symptoms generally. And basically what they found was that in the Parkinson's group, whether they had other visual problems or not, the Parkinson's group had a greater prevalence or a greater rate of symptoms related to their eyes. And those symptoms varied from like tired eyes, tearing eyes, etc. And again, that's just the breakdown. I think that Lisa is going to help me to get some handouts to you all, or certainly e-copies of the handouts to you, so you can look at them if you wish. And really, the overall conclusion from this study is that participants with Parkinson's have higher scores in terms of visual symptoms, with or without the presence of other ocular conditions. And what they're saying is that this suggests that Parkinson's disease in itself places individuals with the disease at greater risk of visual symptoms. And again, this may seem very basic to you, but this is the first time it's been done properly as far as I'm aware. A lot of the stuff about night driving, about stereopsis, to be honest with you, is probably anecdotal. I can't see controlled treatment trials or controlled observational studies which are showing that, but just wanted to bring that up. I think that's it. I should recognise my sponsors. I got a huge grant 5 years ago from the Ontario Research Fund. It was in total about $5 million, and that's kept my lab going over the last 5 years, and now I'm running out of money, but so I have to start grant writing again. University Health Network in Toronto have been superb in terms of funding students. And then there are two companies I should mention to you, particularly the first one. Optina is a Montreal-based company, and they're the people who were trying to develop the oxygen saturation measuring technique with. And then OptiView is a US company, and we're developing blood flow measurement techniques with them as well. So thank you, and happy to take any questions.
So Dr. Hudson, you mentioned that the Chinese physicians found a layer whose thickness was associated with Alzheimer's disease.
Yes.
I guess two things. One, that's the first study, so we don't have a backup study yet.
There are other studies, and one of the things about it is all of the studies are so far relatively small sample sizes, and that's where the Andre study will be different. Instead of like 9 or 10 or even 20 subjects per group, there'll be about 100 in every group.
And can you tell, is that something that local optometrists are looking for this? Is it a specific layer that I can go to my optometrist and say, are you checking for this layer and this thickness, or?
We're not there yet, to be honest with you.
Okay.
To some extent, there are individuals out there who are aware, particularly in relation to MS. We're now beginning to be very cognizant of the fact that certain people with MS or developing MS are actually showing not loss of neural tissue, but they're showing inflammation and swelling of the tissue in certain stages, probably before a flare-up that impacts the vision or visual field as such. Yeah?
Hello. I have Parkinson's. My husband has dementia. And I'm finding that my husband has so many of the Parkinson's symptoms, and he has macular dementia as well. Macular degeneration.
Yeah.
I'm sorry. Yeah. And I don't have that. Are they related at all?
There's definitely a link between macular degeneration and Alzheimer's. That's been published. And there is amyloid deposition potentially in Parkinson's and Alzheimer's, and we're actually interested in seeing if we can measure that amyloid deposition, but in the retina. So we've got some work going on for that at the moment.
Well, I just noticed he's starting to have more of the Parkinson's symptoms than I have.
Yes.
And I don't have macular degeneration, so I'm just wondering. Yeah. With the he gets needles in his eyes every 3 months, and
right.
Are those images that I'm seeing there similar to some of the images you've been showing on the screen?
Yes, absolutely. Probably the drug that the injection that your husband is getting is what's called anti-vascular endothelial growth factor, which it inhibits the abnormal growth of blood vessels in the eye, which is a feature of age-related macular degeneration. So yeah.
Should I say something to the doctor about his condition now showing more of the dementia?
I think you should say more to the dementia doctor. You could mention it to the ophthalmologist, but I doubt it would have a major influence at this moment in time. One of the SDOCT instrument was originally developed for detecting glaucoma, which is a disease where the optic nerve sinks back into towards the brain. It atrophies, and the neural tissue dies. And the changes associated with glaucoma are huge compared to the changes that occur in Parkinson's or Alzheimer's, for example. So we're actually, in many ways, challenging these instruments to see how accurate, how precise they can be to actually detect neurological changes.
Would he be qualified for such a study?
A lot of the studies we try and be inclusive, but at the same time, with something like ARMD, it depends on what stage it's at. So we actually take some people with early ARMD because it's part and parcel of normal aging to develop some level of macular degeneration. It's whether it then goes on to threaten vision that it becomes a problem. So I suspect in your husband's case, because he's receiving the treatment that he is, that we wouldn't be able to take him. But you can make inquiries, and if you want, I'll give you my email address later. You can email me.
What about me to take the study? I don't have the same symptoms as he does.
No, you may well qualify, yes.
Thank you.
Okay. Absolutely, yes. There are 3 recruiting centres. So London is probably the most obvious one for people here.
Who's in London?
Dr. Strong. So Dr. Strong is a neurologist, and I think his area of expertise is Parkinson's. I think. Don't quote me on that. But he's the main lead on the study. He's the person who put it together.
And do you just call his office? Do you get your family doctor to call the office if you're interested?
I think what I would do is I would call his office. The other thing is as well, I can give you a central number of one of the study coordinators. I'll send it to Lisa, and that gentleman will deal with you speedily. I knew we'd get some recruits from this. Thank you.
I was going to say, what about clinicaltrials.gov? Is it registered there?
Oh, it must be, yes.
Okay,
yes,
so that's all you
yes.
go to is clinicaltrials.gov, and all the information will be
thank
listed.
You. Yeah,
you're welcome.
Hi, Chris.
Hiya.
Wow. When I watched you do all those sweat puddles in the gym, I didn't know what you were really doing. Anyway, what I'm going to ask is, many years ago when I was at my eye doctor's, he was telling me that they can tell that someone has MS 2, 3, 4 years before it even starts. So I was wondering, what kind of dialogue can you have? Because he said it's really tricky because you can't just say to somebody who's gone for an eye exam, oh, by the way, because there's it just isn't the ethical thing to do.
No.
So what kind of conversation can we have today? Is it any different? If you can see something coming up and...
Probably what most people would do is actually say, you know, I need you to go and see a neurologist if you're not seeing one already. You would ask them about the family history. Is there anything, you know, telling in that? And it depends on the individual. I mean, some people will then say nothing else, which I have a problem with, because then that person is going to see a specialist and they don't know why. I'd be pretty honest with them and actually say, I've got some concerns that maybe you're developing MS, but typically these people are in the prime of their lives, you know, and you're actually, by telling them that, you're going to give them a devastating next few months if it's wrong as well. It's horrendous. I remember the day, October the 16th, when I was told I had Parkinson's disease and TOS, and there's never been a greyer day since then than that day. Life is better now. Life is brighter.
Thank you so much.
Okay. Any more questions? Thank you.